Yellow fever is an communicable disease. Look at this picture shows that yellowish eyes and virus, yellow fever virus caused by mosquitoes transmission. Detail going on. Introduction. Yellow fever is a viral hemorrhagic disease transmitted by mosquitoes, predominantly in tropical and subtropical regions of Africa and South America. It is caused by the yellow fever virus YFV. A flavirus and has significant public health implications due to its potential for outbreaks and high mortality rates. Definition. Yellow fever is defined as an active viral illness characterized by fever, jaundice, and hemorrhage manifestations. The yellow refers to the jaundice that affects some patients, while fever represents the hallmark elevated body temperature seen in most cases. Types. Yellow fever can be classified into three transmission cycle. 1. Jungle yellow fever. The virus circulates between wild primates and mosquitoes in forested areas. Humans can be infected when they enter these environments. 2. Urban yellow fever. This occurs in densely populated urban areas where the Aedes aegypti mosquito transmits the virus from infected human to others. 3. Intermediate yellow fever found in African savannas where mosquitoes transmit the virus to both humans and non-human primates. Causes. Yellow fever is caused by the yellow fever virus YFV, which belong to the flavivirus genus. The virus is primarily transmitted to humans through the bites of infected Aedes aegypti mosquitoes. Transmission. Transmission occurs when an infected mosquito bites a human. Mosquitoes acquire the virus by feeding on an infected primate, human or non-human. The virus replicates in the mosquito, and the mosquito can then transmit it to another host during subsequent feedings. 1. Sylvatic cycle. Primates are the main host and mosquitoes serve as the victor. 2. Urban cycle. The virus is transmitted between humans via Aedes mosquitoes. Risk factors. 1. Geographic location. Endemic areas including tropical region of Africa and South America. 2. Lack of vaccination. Unvaccinated individuals are at high risk when traveling to living in endemic areas. 3. Mosquito exposure. Spending time outdoors in areas where the Aedes mosquitoes are active increases risk. 4. Occupational exposure. Forest workers. Researchers in endemic regions are at high risk. 5. Travel. International travelers to areas where yellow fever is endemic are at high risk if they are unvaccinated. Complications. Complication can include 1. Liver failure leading to jaundice. 2. Kidney failure. 3. Hemorrhage, bleeding from the nose, mouth, eyes, stomach. 4. Shock. 5. Multi-organ failure. 6. Death in severe cases. Mortality rate in severe yellow fever can reach 50%. Pathophysiology. After transmission via mosquito bite to the yellow fever virus replicates in regional lymph nodes. It then spread to the liver, spleen, bone marrow and kidneys. The virus primarily targets the liver, leading to hepatocellular damage and subsequent jaundice. The immune system responds, but in severe cases, the inflammatory process can lead to vascular leakage, bleeding, and organ failure. Hemorrhagic manifestations result from the disruption of dotting mechanisms. The pathophysiology of yellow fever can be broken down into following step by step process. 1. Virus transmission via mosquito bite. 2. Primary replication in local tissues and dissemination in the bloodstream. 3. Systemic dissemination to target organs, liver, spleen, kidneys. 4. Liver infection and hepatocyte necrosis. 5. Jaundice due to bilirubin accumulation. 6. Coagulopathy leading to hemorrhagic symptoms. 7. Cytokine storm causing vascular damage and leakage. 8. Multi-organ failure liver, kidney, heart. 9. Hemorrhagic phase with internal and external bleeding. 10. Shock and death in severe cases. This cascade of events explains the progressive damage seen in yellow fever and the reason for its high mortality in severe cases. Signs and symptoms. Yellow fever has 3 stages. A. Early stage acute phase. Symptoms: 1. Sudden onset of fever. 2. Headache. 3. Muscle pain, particularly in back. 4. Nausea and vomiting. 5. Fatigue. 6. Red eyes and flushed face. B. Remission phase, if applicable. 1. Symptoms may improve and some individuals recover. C. Toxic phase in severe cases. Symptoms: 1. High fever returns to jaundice, yellowing of skin and eyes. 3. Dark urine. 4. Vomiting blood. 5. Abdominal pain. 6. Bleeding from the nose, mouth and eyes. 7. Organ failure, liver and kidneys. 8. Death can occur within 7 to 10 days of onset in severe cases. A diagnosis: yellow fever is diagnosed through a clinical evaluation based on history, symptoms and potential exposure. B. Laboratory test. 1. Serology, detection of specific antibodies IgM and IgG to the virus. 2. PCR, polymerase chain reaction, detect viral RNA in blood samples. 3. Liver function test, elevated liver enzymes and bilirubin levels indicate liver involvement. 4. Complete blood count, leukemia and thrombocytopenia may be present. Nursing diagnosis. 1. Risk for infection related to viral transmission. 2. Active pain related to fever and muscle pain. 3. Impaired skin integrity related to bleeding. 4. Risk for fluid volume defects related to vomiting and hemorrhage. 5. Infective tissue perfusion related to shock or multi-organ failure. 6. Risk for impaired liver function related to yellow fever virus affecting hepatocytes. Management. There is no specific antiviral treatment for yellow fever. Management focus on supportive care to relative symptoms and manage complications. 1. Hospitalization for severe cases with organ involvement. 2. Intravenous fluid to maintain hydration and electrolyte balance. 3. Pain relief using analgesics to manage fever and muscle pain. 4 blood transfusion for hemorrhage complications. 5 renal dialysis if kidney failure occurs. 6 prevention of secondary infection care to reduce the risk of infection in patients with severe immunosuppression. Treatment. One hospitalization is necessary for severe cases. 2 fluid and electrolyte balance to maintain hydration and kidney function. 3 blood transfusion if there is significant bleeding. 4 medication to manage symptoms and prevent complications. 5 intensive care for patients with multi-organ failure. Psychosocial medicine. The patients diagnosed with yellow fever, especially in severe stages, may face psychological distress due to the uncertainty of outcomes, isolation during treatment, and the fear of death. Addressing these needs involves 1. Emotional support, providing resource and psychological care to counseling for patients and families to help cope with illness. 3. Education on the importance of vaccination for prevention and understanding the disease. Prevention. 1. Vaccination. The yellow fever vaccine is highly effective and provide lifelong immunity for most people. It is recommended for those traveling to or living in endemic regions. 2. Mosquito control. Mosquitoes include using insect repellents, wearing protective clothes, using mosquito nets, and reducing mosquito breeding sites. 3. Travel precautions. International travelers to yellow fever endemic areas may need to show proof of vaccination. International certificate of vaccination. 4. Public health campaign, educating communities in endemic areas about mosquito control and vaccination. Conclusion. Yellow fever remains a significant public health challenge, particularly in endemic regions of Africa and South America. Despite the availability of an effective vaccine, outbreaks continue to occur due to limited vaccination coverage and poor mosquito control. The disease can progress from mild symptoms to severe and potentially fatal outcomes. Early diagnosis, supportive care, and prevention through vaccination and mosquito control are key to reduce the burden of this disease. Thank you. Have a nice day.